Sorry, we're a few minutes late. So welcome everybody to our webinar here on the theme of health data science at population-wide scale. It's being hosted by the Applied Research Collaboration Northwest Coast Methodological Innovation Development Adaptation and Support theme. So it's a bit of a mouthful. So it's the MIDAS theme, and we are the Medical Statistics subgroup. And I'm Catherine Tudor-Smith, and I'm the current chair of the subgroup. So we are still very much in our infancy as a subgroup, and keen to engage with enthusiastic researchers with an interest in medical statistics across the region. So if you do like to hear more about the subgroup or suggest topics for any future webinars, and do please feel free to get in touch with me. My email's on the slide there, and also some more information about the ARC Northwest Coast on their website there. So today I've got great pleasure in introducing our two speakers. Professor Cathy Sudlow, who's the inaugural director of the British Heart Foundation Data Science Centre, which aims to improve the public's cardiovascular health through the power of large-scale data and advanced analytics across the UK and beyond. She's also chair of neurology and clinical epidemiology at the University of Edinburgh, and previously director of the Centre for Medical Informatics at Edinburgh as well, and was the first research director of HDR UK in Scotland, and previously chief scientist of UK Biobank. And our second speaker is Professor Angela Wood, who's professor in biostatistics at the British Heart Foundation Cardiovascular Epidemiology Unit at University of Cambridge, and also member of the British Heart Foundation Centre of Research Excellence and also HDR UK. So Angela's research interests are centred on the development and application of statistical methods for advancing epidemiological research, and she's focused on developing statistical methodology for handling measurement error, repeated measures of risk factors, missing data problems, multiple imputation, and risk prediction and meta-analysis. So really, really great to have both of you here today. So thank you very much. We'll have some time at the end for questions. So if you could please raise your hand at the end of the two presentations, and we can take questions at the end of the webinar. And also, just to let you know, the presentations are being recorded, so you may wish to turn your videos off, and also if you could keep your microphones muted throughout, please, to stop any background noise, that would be really useful. Thank you. So without further ado, I'm going to hand over to Cathy for the presentation. Thank you, Cathy.
Thanks very much, Catherine. And hopefully, since we did a check, the screen share will work okay. So has that come up in slideshow format?
Yep, that looks good.
Excellent. Okay, so hopefully it'll move forward as well. We'll give it a go in a moment. Yes, I'm presenting this on behalf of both myself and Angela, I've had the pleasure of working closely with Angela over the last couple of years on the work that we're going to present to you. Oh, I've gone too far now. So has that slide moved on?
Yeah.
Great. Okay. So just a little bit of background about the BHF Data Science Centre. So we're a centre embedded within Health Data Research UK. Health Data Research UK itself is a relatively young organisation. It's a new-ish UK-wide institute for health data science, and it was launched in April 2018. The director is Andrew Morris, and the British Heart Foundation Data Science Centre, thanks to the prescience and investment of the British Heart Foundation, was embedded within the within HDA UK and launched at the beginning of January 2020. So we have spent most of our young life in the midst of the pandemic. That spared me having to travel from Edinburgh to London on a weekly basis for the first couple of years, but I'm now starting to do that. And from my previous roles, I was well used to that kind of lifestyle, so I was very much up for it. So our vision within the centre is to improve, as Catherine said, is to improve the nation's cardiovascular health using the power of large-scale data and advanced analytics across the UK, with international outreach and intentions beyond that as well. So actually it's a very similar vision to the vision of HDI UK, but doing all of that through a cardiovascular and increasingly cardiometabolic lens. And Health Data Research UK itself sees itself as covering a range of areas of activity facilitated by partnerships. It and the BHF Data Science Centre are essentially organisations that are there to enable research by the entire research community based in academia, within the NHS and industry across the UK and beyond, through three major kind of components of activity. So the first is about bringing data sets together, helping people to gain access to them and to make sense of them. The second is around improving those data sets and the way in which we use them through data management, data curation pipelines, a whole bunch of tools and methods and hubs of specialist activity to help facilitate the research community make really good use of the data sets. And then the third is about their use themselves across a very broad spectrum, from biomedical discovery through to clinical, coalface and policy relevant research. And obviously doing all of that in partnership with a multitude of stakeholders, most importantly of all, the public, patients and clinicians and other healthcare practitioners. So the BHF Data Science Centre itself, when we were sort of setting out our store early on, we alighted upon 6 major thematic areas for our areas of enabling research. And those were to First of all, we knew that there was a big issue with people being able to access and use nationally collated, structured, largely structured coded data sets. So like HES and others beyond that. And we were very keen to ensure that people could access those data sets and start to work with them at much greater scale and link them together across the entirety of the UK. Secondly, we've also got a theme of activity on the better access to and use of unstructured health data. So by and large, unstructured data, for example, data from images or from free text in electronic medical records, or from electronic signaling data that makes up electrocardiograms, for example. By and large, those types of data are not already collected nationally. So it's not the frustration of not being able to access something that you know exists, but then it seems impossible to get anywhere near. But it's more addressing the challenge of how we can actually bring data sets like these together at scale, link them to other structured healthcare data assets, and make the very most of them, and surface structure from them. Thirdly, we have a thematic area on personal monitoring data, that is a kind of maybe a special case of a combination of structured and unstructured health data that's collected by people, often on their own devices. And again, this sense that it's really only by linking those data that provide often very real-time, highly granular insights into heart rate, continuous ECG monitoring, or at the level of mobile phones and apps, various kind of physiological measures such as step count and the like, that if linked to healthcare records could be extremely useful in research and of course in clinical practice as well, in providing insights for clinicians, providing they can be summarized and made available in a useful form. Fourthly, we've got an area of work that we call computable cardiovascular phenotypes, which is about representing health and disease in computable form, starting with structured data through constructing algorithmic combinations of coded data sets to represent various different types of cardiovascular conditions that can be plugged into analyses without having to start from scratch every time. And we have an area of work on enhancing cohorts where we're working with the community of investigators who have brought together UK-wide disease-based or high-risk cohorts in cardiometabolic space. So stroke cohorts, heart failure cohorts, diabetes cohorts, that kind of thing, where they have a challenge of being able to firstly link the data from their cohort participants to all those national structured coded data sets in a way that is streamlined, safe, secure, and can allow them to enhance the cohort through better retrospective characterization of the participants, but importantly, their prospective follow-up longitudinally over time. And we're setting up a platform to, in partnership with a number of Vanguard cohorts, to set up that capability and also help those cohorts to have a safe way of sharing their data with multiple collaborators. And then we have a work stream or a theme on data-enabled clinical trials, again with a cardiovascular focus, where we've been doing a lot of work in partnership with data custodians and trialists around the country running cardiovascular trials to help them, again, largely with data linkage challenges, but a range of other challenges that clinical trialists encounter in the new era of big data and digital records. And then those are underpinned by a number of cross-cutting activities. And we also have been recently starting to, through partnerships with major charities such as Diabetes UK, launch partnerships where relatively small investments from charities building on the BHF's core investment can allow them to layer on specific activities, particularly those that align well with the kind of circulatory disease and associated diseases initiative to build functionality across our themes in their particular area. And so we're looking at partnerships that in stroke, renal disease, and possibly dementia, which obviously has an important vascular component as well. So just to give you a sense of how that all works, there's quite a growing team of people involved. So we've been lucky enough to appoint a number of associate directors who are all academics working at institutes around the UK who are helping to lead those various different thematic areas. And actually our longest partnership is probably with Angela, who's been working with us on our National Data Asset Programme right from the very beginning. But we decided that we really needed to have an associate director leading that. And so we'll hopefully be, this is a little preliminary, you're getting hot off the press information, but we'll hopefully be making a public announcement about that appointment. But as you can see, we've got Matt Sides from UCL leading on trials, Michelle Williams in Edinburgh, who's a radiologist on imaging, Spiros Dinaxis in UCL on computable phenotypes, Richa Sofat, who's based in Liverpool on our cohorts program, and Tim Chico, who's actually the only cardiologist among this crowd, who's leading on the personal monitoring data, and Ewan Pearson, who's leading on the diabetes catalyst. So a really super team, and it's been an absolute pleasure to start being able to work with them. And I think they're enjoying working with each other as well, and sort of cross-pollinating across the different areas. And then we have a support team who are employed directly by Health Data Research UK, although most of them they're scattered geographically around the country as well. So we meet on York Station platform now on a regular basis. But Lynn Morris is in charge of that team. She's our operations director. We have expert project managers, comms and events, PPIE, and executive support in that team. And then a new team that we've now established to add capability in data management and curation, particularly for the work that Angela will be going into more detail on, led by Tom Bolton and John Nolan. And that's been such a great step forward and starting to fill a gap. And we know that there is substantial unmet needs. So with leveraged funds from elsewhere, we're growing that team and appointing new people. So we've got 2 new starters who've just started with us in Tom and John's team, and with more to come. So I'm gonna finish there and hand over to Angela, but just a reminder of our themes. And today we're going to be focusing on the national the national data assets that we've been bringing together and facilitating access to and grappling with. And Angela will tell you much more about the details of that.
Actually, Cathy, I thought that you were going to continue presenting your slides 8, 9, 10 and 11 to introduce the data resource. Do you want to do that? Or
oh, maybe I am. Maybe I am. Let me just see if there's something more to come. There doesn't seem to be, actually. So
okay. Oh, well, I can start on those, and then
have you got them in your set?
I've got yours, so I can do it from there. So that's fine.
Brilliant. Okay, I'll leave you to do that then. Okay. Sorry about that.
That's okay. So I will just go down. So I'm going to introduce to you let me just move that out of the way, the UK-wide network of national trusted research environments. I'm going to try and use not many acronyms, but one I might keep using is TRE, Trusted Research Environment. And in order to answer some key questions of interest with regards to the relationship between COVID-19 and cardiovascular disease, it was identified really early on that we needed population-wide data across different nations to answer these. Now, for England, at the start of the pandemic, that wasn't available. And so one of the initial goals of the BHF Data Science Centre was to bring together a resource of electronic health record data for England. At the same time, this has been developed also for Scotland and for Wales and for Northern Ireland. Let me just focus on what's been achieved by the BHF Data Science Centre for England. So with partnership with NHS Digital, a trusted research environment was established to secure access to multiple linked data sets for England. Here you can see that within this resource through NHS Digital, they've brought together hospital data, including HES and SUS, death registrations, primary care data, community and hospital dispensing and e-prescribing data, COVID vaccination and lab test data, as well as data from intensive care data sets and cardiovascular specialist data sets and maternity and mental health data. And within the trusted research environment, or actually before it goes in there, NHS Digital has linked these data together using NHS numbers and other identifiers. And then the data is brought together in the trusted research environment. It's securely stored and everything has been de-identified. And that's where approved researchers have secure access to that data and can analyze it within the environment. And originally this was called the CVD COVID UK Consortium, but it's been extended to COVID Impact, where the data set is there at the moment to answer research questions of interest in relation to COVID-19. We might return to that at the end. So this important research enables whole population research on over 55 million people who are alive at the start of the pandemic. So that's around 95% of the population of England. Now, you can imagine there are many strengths of analysing this data. One in particular is having this statistical power, enabling us to have an enhanced precision of findings. It also enables us to look at a wide spectrum of novel research questions. We can study minority subgroups and rare disease subtypes as a couple of examples. And then there's also comprehensive information on a range of characteristics and health outcomes. It includes all ages, ethnicities, geographical locations, and socioeconomic health and personal characteristics, which allows results to have this unquestionable generalizability. And just a note that all these data sets are updated on a monthly basis. Oops. So as I alluded to in the diagram about the trusted research environment, it's not just been focused on England, but there's also been population coverage of access to data on 5 million people in Scotland and 3 million people in Wales. And then there's plans to extend into Northern Ireland. The consortium have access to these linked data sets The consortium currently comprising of over 270 members from NHS and academic organisations. And amongst those, there are around 70 analysts who are accessing these data in the different trusted research environments. There are a number of approved projects that people are working on. And within that, we write protocols and algorithms and share these across the multi-institutional team. And there are a number of published outputs. And here on this slide, I'm just showing a number of the key projects that are underway. They're involved in areas of methodology, for example, data management, analytical methods, and I'll allude to some of those in my next bit of the talk, as well as projects looking at the effects of medicines and vaccinations and different aspects of cardiovascular disease, but also the impact of COVID on things like heart failure. As I said, we're not just focused on cardiovascular. And I'll return to this slide. So Kathy, they were the slides I thought you might do. So I'm just going to stop share and then move on to my my other talk. So now I've told you about the data set. And now what I'm going to focus on is how we've used these data to answer some key questions or really extend our understanding between COVID-19 and cardiovascular disease. So I'm going to go through these 5 different sections. I'm going to go through what have been the challenges of using this population-wide data for research. And then I'll show you some key outputs where we've looked at the association or relationships between COVID infection and cardiovascular disease, COVID vaccination and vascular disease, and also the adverse impact of the pandemic on cardiovascular disease prevention and management. And I'll end up giving a summary and some current directions that we're moving in. So let's start with these challenges. Kind of already alluded to the fact that there are some key and novel benefits of using these data, allowing us to kind of look at the scale and depth and enhance our precision and having this generalizability. And with this, examining COVID trends or any disease trends across a whole population enables us to reliably inform public health policies. And that's what a lot of our work has been motivated by, of answering questions to fill in gaps for the in order to inform public health policy. Of course, there are so many challenges to overcome when analysing data at scale. So for the first time, we've brought together information from 65 million people. I've never dealt with a data set this big. I thought 3 million was big, but we're talking at a huge scale here. So what are the things we've had to consider? But the first and foremost is having this consistent data curation pipeline and quality checks. We focus a lot on how we do this for England, but then we need to transfer how we've done that into Wales, into Scotland, so that what we're creating are consistent data sets in order to run analyses. Even defining our population of interest has been a challenge. It sounds easy to do, and I'll show you some of the difficulties we've had in that. Phenotyping diseases and conditions where using information from multiple data resources, again, requires thought and considerations, accounting for different coding systems, not only across the different countries, but even within the data resources and trusted research environments. We must also carefully select appropriate study designs to help us minimize selection and reporting biases, but whilst optimizing all the available data that we have. And our analytical approaches and the way we interpret the results must fully account for the fact that what the data that we have is recorded data, and it only reflects what I would consider being indirect measures of true health states. So we need to take that into account as we not only analyse it, but interpret the results. We also require well-organised analytical pipelines that we can then distribute between different systems. And we must also be prepared to perform computationally efficient analyses. We found out really early on it was unfeasible to run a series of regression models on 63 million people. So how can we optimize the information, but actually be efficient, both in time and computational power? And we've been very open with our protocols and algorithms. We make these open access in GitHub. Sorry, I haven't got a link there, but I'm sure if you search for this, you'd find it. So I'm going to just go through some of these challenges, which we spent a lot of time on, and you might think some of them are fairly straightforward. But let's start with a population denominator. We know that in 2020, from census data, the England population mid-year estimate of the population of England was over 56.5 million individuals. When we first started looking at the data, and we were looking for distinct individuals across the death data, across the primary care data sets, and the hospital episode statistics or hospital admission data, we actually got over 109 distinct individuals, well above this number here. Now, of course, you can see that there's a great number of people. This is called an upset plot, actually. So where there's a dot, it means data has come from that data resource. So this bit I've highlighted here is suggesting that there's nearly 30,000 distinct IDs that come from individuals who've only got data in hospital admissions. Likewise, you can see there's 4 million people where we've only got data in the death registrations. So we have to rethink how we're going to identify distinct individuals. And what we've done is we've anchored them on the primary care data set. So it's a slightly different upset plot here, but you can see that everyone's got a record here in the primary care data, and 5 million have only got primary care data, but there's 35 million people who've got primary care data and hospital admissions from A&E, APC and OP. You don't really need to know those acronyms. I don't know why I'm saying them out loud, but I'm just trying to explain to you how we've done this. 61 million, still above the 56.5 million, and it has caused us to be slightly concerned. But actually, if we look at the NHS digital website and see the number of patients that are officially registered with a GP practice in January 2020, then they've got 61.5, which is looks very close to this. You still might be thinking, why on earth are we analysing 61 million when we think the estimate is more like this? We've actually done this by region, and not only by region, but by area as well. You can't see all this, so I thought you'd be interested in the Northwest. So I've put this for you here. So what this is on the y-axis is the difference between the GP registered population versus the ONS. So where it's bigger than 0, it means that it's the percentage more that we do have in the GP registered population. And the blue ones are showing the result comparison in 2015, and the red one is in 2020, 2021. And on the whole, you can see that we get these overestimates in the GP registered data in comparison to the mid-year. In particular, you see these peaks, don't we, in Manchester, in Preston, and in Liverpool, and also in Pendle. So why might this be the case? Well, first of all, let's just think why it might be the opposite. So we see in Bury that it goes in the opposite direction. So why might the GP population be less than the population estimate? But first of all, the data set that we have in primary care, it only includes 98% of practices, and it also only includes a subset of records with codes that are applicable for COVID-19 research. So we accept we might have missed some people through this, and it also excludes type 1 opt-outs. We think there are just over 1.3 million of those, and not everyone is registered with a GP. And this might be more true in Bury than other areas. But on the whole, we see that the primary care registered population is greater. And I think the reason for this is that the primary care data includes non-residents, and in particular students. And we see it in all regions that areas with high student populations tend to have much higher numbers of people registered with a GP than the population estimate. And it might include people who are registered twice in their home, but also maybe at a university. We also know that it's got linkage issues in the primary care data. So it's very likely that we do have multiple IDs for the same person. And we should also note that the population estimates might be underestimated, especially for the longer time since the last census date. The only thing I thought was interesting here, because I really like the fact that this does reflect the student populations, but it's not so in Lancaster. You might have your own reason why this might not be the case, but I'm aware in Lancaster that there's a GP practice on the Lancaster campus, and I wonder whether they are extra efficient at making sure that patients aren't included twice. Anyway, that's just my hypothesis. Other people on the call might know more. Let me move on from that. So we now feel fairly happy with where we're at getting the denominator population. Another thing we've spent a lot of time on is how we would ascertain particular conditions of interest, in particular for COVID-19 infections. And there are 4 data resources where we can get this information from primary care, from COVID lab test data, from death data, and hospitalisation. And all of these data resources have different codes to ascertain whether a person's got a COVID-19 infection and the severity of that. So you can see the importance here of using multiple data resources for developing and evaluating COVID-19 phenotypes. It's especially important due to the fact that testing procedures were not widely available at the very beginning of the pandemic, but also now later on. So we will not be getting all of our coding from the lab test data alone, but we will be relying on the primary care data and death and hospitalisation. And then, of course, we want to separate out different COVID-19 phenotypes. So we might be interested in hospitalised COVID or death from COVID as well. So that's why this is such an important piece of work. This has been led by a team at UCL by Spiros Denexis and Johannes and Chris. So you can read more about this. This has now been accepted in the Lancet Digital, I think. But from this, in mid-February 2020, we found that there were 3.5 million people with COVID-19. This corresponded very well with the Public Health of England official statistics. And for the purpose of the work that I'm showing today, well, actually, I can't remember where I go up to. It might not be up to this point. But from here, we can see 3.1 million had a positive test, 2.4 have been diagnosed in primary care, and just over 364,000 have been hospitalised with COVID by mid-February 21. So likewise, combining different data resources is also essential for ascertaining other conditions, such as the vascular diseases that I'm interested here. Here I've shown you it for incident stroke and for myocardial infarction. Again, showing the importance of bringing information from primary care, hospital admissions and the death registry to get all the patients who've been affected by incident stroke, TIA or myocardial infarction as shown here. So, for example, if I didn't include hospital admissions when ascertaining myocardial infarction, I'd lose 20% of these important endpoints or cases. We've also been very careful to design our analysis to overcome some of the other challenges I've mentioned. So for the analysis I'm presenting today, I am focusing only on adults, on 48 million adults. We've carefully selected follow-up periods to handle secular changes and reporting practices. So when we've been running analysis looking at the relationship between COVID-19 infection and vascular disease, we've started all of our analysis in the early part of the pandemic, ending on the 7th of December in 2020, which is the date when the vaccination rollout began in England. And likewise, when we've looked at the association or relationship between COVID-19 and vaccination and vascular disease, we've restricted this between the 8th of December in 2020 up to the 18th of March in 2021. And this date was chosen because it was this date when some rare events following vaccination were reported in the press, and patients and clinicians were aware that there was some side effects of vaccination, and this might have affected reporting practices after this date. For our analysis, we've chosen to use Cox Models using a cohort study design. This allows us to account for secular disease trends over the pandemic. And we've used a time-dependent exposure, allowing us to assess the impact on risk for different time periods after COVID. We've also adjusted for many confounders. And what we've done is we've performed analysis separately in England and Wales, and then done a meta-analysis to combine them. For the analysis I'm presenting today, we haven't quite yet incorporated the Scotland data, but other teams within our consortium have been able to achieve that. I just want to tell you a bit more about the cohort study design. Do you remember me telling you that we found out quite early on it was unfeasible to run analysis on 63 million people, likewise even for 48 million adults. And so we've proposed to do some random sampling in order to run efficient analysis. So in all of our analysis, we include people with the outcome of interest, such as a vascular disease, and then a 10% random sample of all other people. So this isn't a case control. Some of you might be thinking, oh, this is just a case control analysis. We're still doing this as a time to an event analysis. We're treating it as a cohort. And what we're doing is we're incorporating inverse probability weight with robust standard errors to account for this sampling. Now, you might also be there thinking, why on earth did we choose 10%? You're absolutely right. We chose 10% because it just seemed a sensible number at the time. But since then, we've investigated this sampling fraction to quite a great extent. And what we found is that the hazard ratios and 95% confidence intervals that we were interested in actually didn't vary that much from 50% sampling to around a 0.1% sampling. But what did vary was the amount of time it took to run these things. Anything below 1%, we found it didn't make much difference, but really the lower the sampling fractions, it dramatically changed the running time of these. And of course, actually, what we found is that the variation in the standard error, which we'd be most interested in looking at, is driven by this control to case ratio. And we found that there was no detectable gain beyond having this ratio of 10 controls to each case. And that's a well-known finding in case control analysis anyway. So they were the main challenges. They're not the only ones, but they're the main ones I'm going to go through today. And now I've got a number of slides which are showing you some of our key results and outputs. So I'm going to start with looking at the relationship between COVID infection and cardiovascular disease. And what we found is that there's a higher risk of major vascular disease following COVID-19 infection. So these figures show the hazard ratio on the y-axis for the time-dependent association between time since COVID-19 on the x-axis. We've got the risk of arterial events on the left and the risk of venous events on the right. Now you'll see that immediately after a COVID-19 infection, the incidence of arterial events started off being, I think this is around 22 times higher immediately after. But we can see that this rapidly declined to a fairly consistent but elevated risk of around 1.3 times higher between 13 and 49 weeks since COVID. These results are compared with individuals who never got COVID or before they got COVID-19. Likewise, if we move over to venous events, we can see that this was also immediately higher after diagnosis, if in fact even higher, and actually declined more slowly to around a twofold higher risk after 30 weeks. The difference between the grey and the dark black lines is with adjustment for age, sex and region, and then more extensive adjustment. And we do see some attenuation following that adjustment. And we could argue that perhaps there's some unmeasured confounding might remain. But the key thing about these results is that they continue to support policies to avoid COVID-19 infection with effective vaccines, and also the use of secondary preventive agents in high-risk patients after COVID. The hazard ratios were higher and remained elevated for longer following a hospitalized COVID, shown here in the darker orange, versus non-hospitalized COVID, shown in the lighter orange. These results are particularly noteworthy because the elevated risks are still remaining for the more common and less severe COVID infections and have a wider implication for the population. And then just another one, we've looked at various subgroups for these analyses, and here I'm showing you them by the different ethnic groups. And what we found is that the highest risks were generally amongst the non-white ethnic groups. And this is a finding that does require further investigation, but can only be investigated using data at this population-wide scale. So now I'm going to move on to some results in a separate analysis where we've looked at COVID vaccination and vascular disease. So here what we're showing generally is that there are lower risks of vascular events following a first COVID-19 vaccination, especially in older individuals. Now, of course, this makes complete sense, because if people are getting the COVID vaccination, then they're avoiding COVID, and therefore avoiding the higher risk of some of these infections that would have been induced by a COVID-19 infection. We see it in particular in those aged over 70. We accept that some of this could be due to residual confounding, but most of it is, as I said, due to this reduced COVID-19 infection. So we did this for venous thrombosis and also for arterial thrombosis. The blue is for the AstraZeneca vaccine, red is for the Pfizer vaccine. These are all fully adjusted. And again, they're time since vaccination analyses. So on the X scale, it's 28 days within vaccine or after 28 days of vaccine, and the reference is pre-vaccine. We had 21.2 million people having first vaccine in this follow-up. We repeated the analysis looking at lower limb fracture as an outcome, really as a control for potential confounding. And we saw that there's really no clear effect on lower limb fracture, especially in those under 70, perhaps a little bit for those over 70. But this is suggesting that we've got fairly good control for the younger age group for confounding. But these actually weren't the key disease endpoints of interest. There are some rare clotting diseases that were being reported early on in the pandemic, and these are the results that I'm showing here. Two in particular, intracranial venous thrombosis and thrombocytopenia. And what we see is that there are higher risks of these rare blood clotting diseases after the AstraZeneca vaccine, shown in blue, but not for the Pfizer vaccine, shown in red. And that this is much more, you can see this much clearly in the under 70s than in the over 70s. Now, just a note about these rare blood clotting diseases, they are incredibly rare. For example, pre-pandemic in 2019, the intracranial venous thrombosis rate was around 3 cases per million per month. These analyses are suggesting that there's a 2 times risk with the AstraZeneca vaccine in those aged under 70. So we might expect this to increase, should say by up to around 6 cases per million in a month post-vaccination. So I really want to stress how these results should be put in line with the previous results with regards to avoiding COVID-19 with vaccination and considering both of these together. We've also considered the risk of myocarditis and pericarditis. Again, this was another proposed disease following vaccination, in particular, I think for the first or second dose vaccination that I'm showing here. This analysis was run in those over 12, so we've got it amongst 52 million people. Here, the blue is the Pfizer vaccine, the yellow one is the AstraZeneca vaccine. These results show that we didn't see any clear evidence actually of an increased risk in either myocarditis or pericarditis after the first or second dose of either of these vaccines. We looked to see whether this varied by different ages or by gender, and still found no clear evidence. And these results actually do contrast from those from other groups. In particular, there's been publications from Israel and also in England using a self-controlled case series approach. which suggests that there is an increased risk of myocarditis and pericarditis amongst younger males after the second dose. So we're continuing to investigate this, doing a deeper dive into a comparison, a methodological comparison of why other groups are getting different findings. And finally, I just want to show you a set of figures from our colleagues, Caroline Dale and Richa Sofat, where they've been using this population-wide data to understand how the pandemic has affected the medicines that have been dispensed across England, Scotland and Wales. So this has used information across all of these three nations. What they found is that the incident use of hypertensives, of lipid-lowering medications and diabetes medications, but not insulin, fell dramatically during the 2020 and 2021 pandemic period in comparison to the pre-pandemic you see here. So there's a real drop in the dispensing of these drugs. And in fact, over 500,000 fewer people than expected started any hypertensive treatment in England, Scotland and Wales. And they've done public health modelling to show that this under-treatment of hypertensive drugs will actually cause in the future over 13,000 additional vascular events, over 2,000 additional myocardial infarctions, and over 3,000 additional strokes. So there's major concerns of this sudden drop in medicine dispensing and how that will affect subsequent diseases. So just to summarise, during the COVID-19 pandemic, through the British Heart Foundation Data Science Centre, it's become possible to conduct research of clinical and policy relevance at a UK population-wide scale using these nationally linked health data. It's enabled many well-powered studies, including the ones I've shown today, where we've investigated the vaccine safety, investigated the elevated risk of arterial and venous vascular events over many months after COVID-19 infection, and also on whole population dispensed medicines data. We've defined COVID-19, its severity and different trajectories and mortality at a whole population scale, and also done whole population modelling. Actually, I haven't presented this using all of this does this multi-source linked health data for pandemic preparedness. Let me just highlight some of our current directions. Here I split it into methodological and applied analyses. So we're still working on having what I would call modular data curation pipelines. This has been the most timely part of any of these analyses. And what we want to create a data curation pipeline so that each new analysis doesn't need to redo the same thing, but we can build on that. We're also moving towards what I'm going to call efficient federated analyses. I still always believe that we will run analyses, say, in different nations. What is difficult, though, is actually sharing code between the trusted research environment. So how can we have a code sharing space that enables us to be more efficient? At the moment, what we do is we write the code for England and then move it into a data set for Wales and for Scotland. But I think there's better ways to do that. I've already alluded to the fact that we're doing this comparison of different designs, comparing the cohort design with a self-controlled case series approach. We're also working on phenotyping at more detail different health conditions using rich registry data, which is available on subsets of the individuals, and then thinking how we can impute information from that to full population scale. And then I've already alluded to this, how do we combine population-wide data, not only from England, Scotland and Wales, but also in Northern Ireland and beyond. So there's some of my key goals for the next 12 months and beyond. But what are some of the applied analysis that in particular I'm working on? There's much more on behalf of the BHF Data Science Centre, but I'm interested in how the results I've presented today compare those with those from the era of the Delta, amongst those who are fully vaccinated and also amongst those who've chosen to remain unvaccinated. How do the results compare with other flu outbreaks before this pandemic? Also looking at the risks of other common chronic diseases, including mental health problems and renal function and cancer. We focused a lot on adults, but there's a huge interest in the interplay between COVID-19 infection and vaccination for those under 18, and also during pregnancy. And finally, I think both Kathy and I really want to acknowledge that all of this is only possible through national coordination and a team science approach and public support. There's an infrastructure and partnerships have developed during this remote working of the pandemic, which I would never have been involved with otherwise. And from that has grown a really strong multidisciplinary and multi-institutional team. We benefit hugely from the public and patient advisory panel that we have, and also from the expertise from the NHS digital team. And Kathy and I, well, that brings me to the end, and Kathy and I would be delighted to take any of your questions on this. I'll stop sharing.
Thank you both, that was excellent. So open up for any questions from the audience. Whilst we're waiting, there's a couple in the chat. So there was a question for Kathy. What is your experience of getting access to the CPRD database, and have you any advice for researchers about it?
Not really. So, I mean, I do have some experience of working with CPRD from my UK Biobank days. And back then, CPRD was aiming to expand its coverage of primary care data in particular, which has always been the holy grail, to about a 10% of the population to much broader comprehensive coverage. Their mechanism to do that was to seek permission from each individual GP practice using a sort of foot soldier approach. And I think by the start of the pandemic, they were sort of getting up to about 15%, but it was nothing like the coverage that was going to be required for a cohort that had a UK-wide footprint or an England-wide footprint that wanted to link to primary care data. So, and then when I moved from UK Biobank over into taking this BHF Data Science Centre role with a kind of population-wide ambition, it didn't feel like CPRD was necessarily going to tick that box. So, of course, for some population-based studies where a population of up to about 10 million or so is big enough, and the linked data that CPRD can pull in on top of that, if you can afford the licensing fees, that's going to be great, particularly for users familiar with CPRD. But the ambition was always really to go beyond that to UK-wide scale, particularly for some of the use cases like the ones that Angela presented. So where you've got rare events like funny vaccine side effects and you really need a whole population, or you want to study relatively common events, but over a prolonged period of time and chunk that time up into small components, where again, you start to run out of outcomes unless you've got a very large population to start with. We knew we were going to need to go population wide, so we knew our partnership was going to have to be with a national system. So that was why we created this partnership with NHS Digital, so that they had a trusted research environment to populate with population-wide data, complementing the Scottish and Welsh environments that were set up prior to the pandemic and have improved since. So the primary care data story is that there is this primary care data set that Angela was describing, which contains within it all the codes that the GP extraction service in NHS Digital has ever asked for. So there's about 35,000 SNOMED CT codes in there. And I think that's why its population coverage is so wide, because they're such broad and general codes that most people have at least one of them in there, even if it's from the past. So that's been a really useful data set to start to get familiarity with in advance of NHS Digital pulling in a more comprehensive data set at national scale, which, as you know, has stalled, but is going to be up and running again next year with a following wind and a much wider consultation. So yeah, sorry, that's a rather long-winded answer.
Okay, thank you. And another question, this is for Angela. Are your databases suitable for analysing appropriateness of prescribing practices for various conditions?
So in terms of the data are there. My question would be, so all, you know, we would have the data on what's been prescribed to individuals in the primary care setting and also dispensed at in hospitals. And you saw in that final analysis, I was kind of showing how prescriptions have changed over the pandemic and so on. So Milan's, yes, they're suitable, or they contain the data that would allow you to do it. I'm just cautious about, I don't exactly know what analysis you have in mind of appropriateness of prescribing practices, because most individuals are prescribed medicines based on how the GP or consultant will deem is appropriate for their disease, if that makes sense. I think you might know what I'm getting at. I'm getting on the confounding by indication problem when you start analysing medicines and try and think, was that the best medicine for that person and so on. So I think there's difficulties in analysing it, but the data are there. Does that help your answer, Milan?
Yes, thanks very much.
Thank you. Ollie's also asked a question. You have a lot of SQL on GitHub. Have you found it hard to find people who understand how to write SQL?
Ollie, what a fantastic question, because I certainly haven't explained that is, I didn't put that down as one of the challenges today, and that really has been the biggest challenge of these data, is when you're working with 55 million, 60 million individuals, using R really isn't that efficient, and so alternative ways to curate the data using things like SQL or Python are needed, and that's how the trusted research environment is set up. Many of the people on this call have probably got some kind of statistics training where we learn how to do R or Stata or other things. We don't get taught how to do Python or SQL. And so it has been a major barrier for analysts to get going with the data. And for this reason, as Kathy explained in her talk, we're growing a team of health data scientists to work alongside analysts to help them with that early part of data curation. And it's why I said I feel one of our greatest areas that we're developing is getting this modular curation process set up so that new analysts can just get going and not reinvent things. Does that help, Ollie? Okay, I presume it does, yeah.
I think so.
You feel our pain, thank you. I think what it is people just have different training. We've had amazing people who've just been so good at SQL, but then actually can't run the analyses. So this is why teamwork is so important in any of these population-wide analyses.
And maybe the other thing I would add to that is that, of course, we've also recognised through this process that once you start to move towards fixing access, then you know, the challenges of analysis become the next issue that need to be dealt with, and Angela's illustrated a number of those really well. But we've also realised that there are actually people out there who are keen to do this management curation work, which often takes up about 70% of the project, between the brilliant idea at the start and the analysis of a research-ready data set at the end, which is what the kind of traditional academic researchers based in universities are really good at. And that bit in the middle is something that we I think struggle to build the teams to support, and that's partly because of the way the academic reward system and career system works. These people have often been regarded as technicians, not an intrinsic part of the academic team, and because they're not always first and last authors, but contribute across a multitude of projects, their careers are often not supported as they should be, and yet they are fundamental to and underpin so much of this work. So another work stream that the BHF Data Science Centre is championing, but that HDA UK is also focused on, and indeed the research councils are kind of, you know, getting their heads around now, is this support for health data scientists and data scientists more broadly, who work within teams and and provide all that kind of fundamental underpinning capability. And Ollie, it sounds like Ollie's one of them, right? There you go, Ollie. Well, you can speak to this from personal experience then. And we value you, and so do your colleagues.
There aren't enough Ollies, unfortunately. Are there any other questions? Well, it's been really interesting and informative, and clearly lots and lots of work has gone into the work behind the presentations today. So thank you very much, and it's thank you very much for giving up your time. I know you're both really, really busy. Yes, there's going to be the presentations have been recorded and will be presented on the ARC Northwest Coast website, I think. So should be able to disseminate the slides through that.
Yeah, we can certainly pull a combined slide set together and circulate that. And my apologies, Angela, that I let you pick up on my final few slides. I did actually have them. I just somehow couldn't forward the slides at that point, so which is why I sort of stalled. But actually, our consortium, which is facilitating access to these data, is completely open and inclusive. Anyone on this call can join it. It's very, very straightforward. And if you do have questions that you're keen to work on using these data, then we'd be very keen to facilitate your access to them. We have a pretty straightforward procedure. The questions have to have something COVID-y about them. So add a COVID twist to your PET question, or if you have a genuinely totally COVID-centric question, of course, that's fine as well. And you can find out lots of information on our website. But anyone who wants to, in fact, I'm going to stick an email in the chat, the person to contact, the relevant project manager. If you want to join the consortium and find out more and come to our meetings and so on, then please do. It's an all-comers setup.
And I might just add something about the CPRD question at the start, actually. So for me, I think when I first applied for CPRD, it probably took 9 months for start to finish to get the data. Once you've got a project here, you get access within 2 weeks. It is an incredibly amazing, fast process and efficient process. So I hope that's encouraging as well.
Oh, that's impressive. Right, well, I'll bring the meeting to close, and thank you both again, and see you soon. Bye.
Thank you for having us.
Thank you.
Bye.